we can proceed further with radiology imaging, and it will be a little bit different radiology. It will be nuclear medicine and prostate cancer detection. And I'd like to invite Dr. Sigitas Tiškevičius, again from National Cancer Institute, to present us the new things in this field. What can we do? Hello, Sigitas. Are you with us?
Hello, can you hear me?
Yeah.
Hello.
Yeah. We can hear you.
So,
yeah. So
okay, shall we start?
Let's go and start your presentation about what can we do for prostate with nuclear medicine.
Okay. So, dear colleagues, let me introduce myself. My name is Sigitas Tiškevičius, and I'm a radiologist working in nuclear medicine department at National Cancer Institute. The topic of my today presentation is nuclear medicine in prostate cancer detection. And tomorrow and on the last day of the conference, there will be 2 lectures about PSMA PET presented by my colleagues from Riga and Tallinn. So I focus on the nuclear medicine imaging beyond PSMA PET. And let's start with conventional nuclear medicine. And the most common examination in bone scintigraphy, or also known as bone scan. This is summary table from prostate cancer guidelines of European Association of Urology. And as we can see, in intermediate risk disease, a high risk localized disease, local advanced disease, we may find bone scanned and cross-sectional imaging of abdomen and pelvis as well. The clinical indication for bone scan in oncology, of course, is bone disease, bone metastasis, present or suspected, especially for solid tumors with high affinity for bone, such as prostate cancer. The second indication is treatment monitoring. And in nuclear medicine, we have an option not only to assess the images visually, but also to perform some quantitative evaluation. For example, we can use one of the commercially available computed systems, such as bone scan index or BSI. The bone scan index is the percentage of the metastatic affected bone related to the whole skeletal mass. And here we can see an example. This is the same patient and 2 scans of the same patient. The red dots are metastatic affected bones, and we can see that bone scan index demonstrate worsening of the disease, cause the percentage of affected bone increases. Another novel technique is quantitative bone SPECT. From the SPECT CT images, we can calculate the radioactivity concentration. It's similar like SUV values in PET-CT examination. And all the modern gamma cameras, SPECT-CT gamma cameras, they are capable to perform such calculation. Also, the gamma camera we are using in our nuclear medicine department, we also sometimes perform the quantitative bone SPECT. Also, we have to perform bone scan before or prior to radionuclide therapy of bone metastasis, because the tracer or agent used for bone scan, the uptake pattern of this agent is similar or same like radionuclides used for therapy. So we can predict the uptake of radionuclides used for therapy or perform some dosimetry calculation. When we are talking about bone scintigraphy, we have to keep in mind that this is imaging of bone metabolism or bone turnover. And the metastatic site exhibits increased bone metabolism, so we can image the metastasis and see on the scans as a hot spot. And we have a dozen of different imaging modalities for prostate cancer. Is CT, MRI, PET with different tracers. And we have to keep in mind that all these modalities images different effects. So sometimes we see the discrepancy when we look at the radiology reports. And this is one of the examples. We have prostate cancer patient who undergoes initial staging. On the left side, we can see the very nice, crispy bone image of CT. And the report states that there are 4 lesions in skeleton suspicious for bone metastasis. And on the right side, this is SPECT CT of same patient. And here we can see multiple bone metastases as hot spots through whole axial skeleton. And as we can see, we can image the changes in bone metabolism earlier than they appear on anatomical images like CT. While performing bone scintigraphy, we can image the patient using different protocols. For example, planar whole body imaging, or we can do the tomographic examination, also known as SPECT, single photon emission tomography, or we can combine SPECT with the CT imaging and look at the fused SPECT CT. And this is example of whole body planar images in anterior and posterior projection. It a bit resembles X-ray images in 2D dimension. And here is an example of SPECT image. It resembles a bit computer tomography. We look through the images in 3 planes, and also we radiologists or clinicians like this rotating or multi-intensity projection images. And nowadays, most of the gamma cameras sold in the market are SPECT CT. This means that such a scanner combines the gamma camera itself, and also there is computer tomography built in the same gantry. And here is an example of bone SPECT CT imaging. We can see the CT image with fused or, let's say, superimposed SPECT images over. So the color scale is SPECT image and the grayscale is CT. So if we look back at the prostate cancer guidelines from European Association of Urology, in the staging chapter, we may see that the sensitivity and specificity of the bone scan doesn't look very impressive. But if you look at the reference, this is the meta-analysis from 2014 published in Skeletal Radiology. Those figures are from plain whole body imaging, and this is not the figures which responds to SPECT or SPECT CT. So is the bone scan only planar whole body imaging? I am a bit cautious about that because The current standard for bone imaging is the whole body SPECT-CT imaging, or at least SPECT. And all nuclear medicine department in Lithuania, they all are equipped with SPECT-CT scanners. And as far as I know, all the departments in Lithuania are using the SPECT-CT protocol for bone imaging. And this is data from more recent meta-analysis from 2020. And if you look at the sensitivity and specificity of a whole body SPECT-CT, so it's above 90%. During the next day, there will be at least 2 lectures about PSMA PET. But there is an option to perform PSMA imaging with conventional gamma camera. PSMA PET has advantage over the SPECT imaging as the resolution of the spatial resolution of the PET-CT is higher than SPECT. But PSMA PET is expensive examination and not available in all PET centers. So the PSMA SPECT imaging may address this problem because the SPECT imaging is not so expensive and even may call it cheap. And technically, it can be done in every nuclear medicine department. At the moment, there is no PSMA SPECT tracers available in European market, but our department has participated in clinical study, and we have the experience with PSMA SPECT imaging. We received the tracer from states-based pharmaceutical company called Lantheus. And this agent is finishing clinical trial phase, and we hope that it will be registered in European market and it will be available for clinical studies. And here is example of PSMA SPECT imaging from our clinical study. This is whole body imaging showing the physiological distribution of PSMA agent. It's physiological high uptake in salivary glands, in kidneys, then there is any abnormal findings. This is another example of the patient undergoing initial staging, and it's biopsy-proven prostate cancer 5+4, and PSMA SPECT images shows a lesion in prostate gland, very high uptake, and pathological lymph nodes on the right side pelvis, in para-aortic region, and also pathological lymph node in the lower paratracheal space. And a few weeks later, this patient underwent the PSMA PET scan, and the findings of PSMA PET were identical to our study. And this conference is online, and actually we can't meet at our nuclear medicine department. So this is the last slide with short presentation of our nuclear medicine department. We have 2 SPECT scanners. One is SPECT-CT, and we perform around 6,000 examinations per year. Also, we have a therapy unit with 12 beds, and around 500 therapy procedures are carried out every year, predominantly by radioiodine therapy of thyroid cancer, followed by radium-223 treatment of bone metastasis. So, thank you for your attention.
Thank you, Sigitas.
You're welcome.
Yeah, I don't see any questions, so I invite everybody to be more active and to ask questions on the Slido platform. As actually it's sometimes looks like that we are talking one to the other, not to the audience. So really be more active and ask these questions to us. And I have a question to you, Sigitas. How do you think how can we improve our nuclear medicine equipment, or maybe these radionuclides? Maybe we need something new things to improve prostate cancer diagnostics and maybe treatment in this field. What's your opinion?
Thank you. I think that the major step will be in PSMA PET studies. And we know that in Kaunas, in second the largest city of Lithuania, there is cyclotron project, and we hope it starts in a year or two. So the tracers for PET will be available in Lithuania, more available. So this is the question of PET scanner. The next step after PSMA PET, I suppose, is theranostic. We have this PSMA PET imaging agent. They are labeled with diagnostic radionuclides like gallium or fluorine, but there is an option to label PSMA molecules with radionuclides for therapy. So it's theranostic, it's imaging with same, let's say, contrast agent, and to perform treatment also with same agent, but with different radionuclides. And PSMA theranostic or therapy, it's already started in Germany. It was developed, I suppose, in Freiburg. And at the moment, you can go for commercial treatment, PSMA commercial treatment in Germany. So I suppose the next steps are PSMA PET followed by radionuclide treatment, targeted radionuclide treatment.
Okay, thank you very much.
You're welcome.
And now I'd like to invite Dr. Ruta Grigienė from National Cancer Institute. Hello,
Good
Ruta.
morning. Hi.
Good morning. How are you?
Thank you. I'm fine.
Ready?
Yes.
Yeah.
Also ready.
So, and I know you are going to do a workshop here, yeah?
Yes. We
So,
will have,
and how it will be going? What's the idea of that workshop?
the idea is just to do some cases, some MR cases, some real MR cases, how we're doing in our everyday practice.
All right. So you will show us the case, and we should decide what's the diagnosis. Yes.
We can do like this, or we can just go through these cases because we have just half an hour. So it will, I think it will take a lot of time to do some polls or something. So I think
Okay.
we will.
So do it quickly. Question answers. Let's go.
Okay. So we will start with our first case. I hope that you can see my screen.
Yes, we can see it.
So the first case 70 years old man, and the MR was done because the PSA was elevated. The PSA was 9.5, so it's not, it's quite high PSA. So how we're going through those images in our everyday practice. So first of all, of course, we have to measure prostate volume. How we do this? Now we will go through T2 images. This is axial T2 image, and as you know from previous lectures, that T2 images are very important for various anatomical variations. And here we can see prostate, yes, and how we do those calculations. So we can measure on axial plane in two directions, yes, and we have 4.6 and 5.8, and we have calculators, so 5.8 and 4.6, and then we will go to sagittal, and we have to measure our sagittal, do sagittal measurements. So, and here we have 6.5. So we have to take in mind that we have to measure all adenomatous nodes. It should be taken into our measurements. And then we will calculate PSA density, which is also very important. So now we have PSA 9.5. So 9.5. 9.5. We will delete from 178, and we have 0.05 PSA density. So PSA density is not so big, not so high like PSA alone. And then we will go to ADC just to take a look if we have any low lesions, low signal lesions, and we can see that we don't have any low signal lesions on peripheral zone, but we have one on transitional zone in apex. So we can go back to T2 just to take a look how it looks like on T2, as in transitional zone the main is T2. So we can see this lesion also here. So according to PIRATES 1.2, we can score this lesion like PIRATES 3, because it is hypointense on T2, and it's have low signal on ADC. And of course, we have quite big hyperplasia of prostate. So hyperplasia is scored like PIRATES 1 on scoring system 1.2. So for this case, it would be final score PIRATES 1 in transitional zone, and PIRATES 3 lesion in transitional zone right apex. So this is quite, I don't know, I think this is quite simple case, and we will go forward to another case, and we will see how it looks, what we will find here. Okay, so as mostly clinical significant lesions are found on peripheral zones. So usually we start with ADC, looking for any clinical significant lesions. So we will start also with ADC, and we can see here prostate from apex. And here we can see some lesion, but we can see that it is in front of the prostate, yes. So we have to go back, of course, we also measured that it is, ADC value is about 800, so it's quite low value. So now we can go back to T2 images and to look how it looks on T2. And this is axial T2 sequence, and prostate, yes, from the apex we're going up. And here we can see hypointense lesion in front of the prostate on the right side, and it is on transitional zone. So the main sequence for transitional zone, as you know, is T2. And of course, we have to go and to look how it looks on coronal plane. So on coronal plane, we also can see this hypointense lesion. And on sagittal plane, we also can see this lesion. So you taking in mind how those lesions should be scored. Everyone you can score by yourself, and of course we have to measure this lesion, and this will be about 1.3, but it is quite big. And if we go back to axial T2, we can see that the capsule is a little bit bulked, and we can, especially if we will take a look to another side of the prostate, so we can see asymmetry, and so it is we have suspicious capsule invasion. So if we have not lesion more than 15 millimeters, but less, if we have lesion less than 15 millimeters, but we have suspicious capsule invasion, so the final score should be PIRATES 5. Okay, we can go to another case. So we will start from T2 axial images, prostate, and we are looking for hypointense focal lesions on these images. We can see that we have some lesion in the apex on the left, and we will go to other sequences our sequence, as we suppose that this lesion could be in peripheral zone. So the most important for us is ADC. And we're looking for low signal on ADC. And we can see that we have this focal lesion on apex on left side of prostate, like hypointense lesion. And then we can measure the value of this lesion. And this is about 800, so it's quite low. And now, this lesion is, we can see quite big asymmetry also here on left side and here on right side. And this here is some suspicious for neurovascular bundle invasion and capsule invasion. Of course, we have to measure this lesion, and this lesion is about 10 millimeters. So according to PIRADS 1.2, it is PIRADS 4 lesion. But as we have also suspicions of capsule invasion, so this should be scored like PIRADS 5, also on ADC, DVI, and also on T2 images. And we also have to take a look if we have any suspicious lymph nodes or any other suspicious lesions. And in this case, we have suspicious lesions in bones. And I have, of course, I haven't said you that PSA was 90, so very high PSA. And of course, we have to be very careful about metastasis when we have so high PSA, not only the primary lesion. As we can see, the primary lesion is quite small, but we have lesions in bones, and we can also take a look to contrast enhancement. Do we have contrast enhancement? And those bone lesions enhance contrast, so this is metastasis. Okay, and we can go to another case. So we will start with axial T2 images. And here is prostate, peripheral zone, transitional zone. And in peripheral zone, we have quite diffuse hypointensity on both sides of prostate peripheral zone. And it's maybe quite suspicious. So we have to take a look to ADC, what we can see on ADC. And on ADC, we have also those, especially on right side, not very low, but and not focused hypointensity. Maybe here a little bit focused hypointensity. Of course, this hypointensity should correspond to high B-value DVI images, where we should find high signal lesion, bright lesion, and we're looking for those lesions on high B-value, and high B-value should be not less than 1,400. And we will see how it is on contrast enhancement, and first of all, we have this first image without contrast enhancement, and we can see that we have bright lesions on T1 FATSAT images. So these lesions, these bright lesions, we also can see those on just the T1 sequence, not without fat saturation. So we have those bright lesions on T1. So we have a huge hemorrhage lesions on both sides. So our score could not be very exact in these cases when we have some hemorrhage, because we can't depict focal lesions which could be in those areas where we have hemorrhage. So we have to be aware that we always have to look for hemorrhage on T1 images, where we can depict them very, very well. Okay, and we also have another case. And again, we will start with axial T2 images. We have prostate, peripheral zone, transitional zone, and as always, we are looking for some hypointense focal lesions on T1. So on these images, maybe we don't see any exact focal lesions. So we will go to other sequences, especially for ADC. And we're looking for any low signal lesions. And we can see here low signal lesion. It's really low on ADC, so we can go back to DVI images, high B-value DVI, and we are looking for high signal focal lesions. So in the same place, we have corresponding high signal on high B-value DVI. So it could be really a clinical significant lesion. So now we also can go back to T2 just to take a look. Maybe we have some lesion here corresponding to those on DVI and ADC. And here we have in the midline on left side of peripheral zone in the middle of prostate near midline. And also we can take a look for contrast enhancement. Do we have in this area any contrast enhancement? Of course, we have to take a look for early phases or for early contrast enhancement, and it's not always so easy on our this software. So we have some contrast enhancement, but even if we would not have any contrast enhancement, we have the main sequence on peripheral zone, and we can see that this lesion is on peripheral zone is diffusion. So on diffusion, we have both high on high B value, high signal focal lesion on high B value, and also low signal lesion on ADC, and also corresponding lesion on T2 sequence. So this should be scored like PIRADS 4. Okay. One more. As you have seen today and also yesterday, when Ruta Grigienė was presenting various cases, you can see that that it's not always very easy to depict those clinical significant lesions. So here we can see prostate, yes, peripheral zone, transitional zone, T2 images, axial images. We're looking for hypointense lesions on peripheral zone, and then on transitional zone, any suspicious lesions, and maybe one on the right side in the basis. But as you saw yesterday, it could be also central zone, so we have to be aware of it, and we have to take a look to coronal images also, how it looks like on coronal images. And also we can find this lesion here near transitional zone, but we can see asymmetry. It's more hypointense than on left side in central zone, and also we have some changes in seminal vesicles. So we will go further to ADC. As you know, when we have some lesion on transitional or central zone, we have to, well, our main sequence is T2, but we also have to go to look for ADC. So we will take a look if we will find something on ADC. And yes, on ADC we can find hypointensity. So this lesion is really not just transitional zone, but this is real clinical significant lesion on right central zone with possible seminal vesicles invasion. So we can also measure this lesion, and it is 1.7, and also with invasion to seminal vesicles. So this lesion, according to PIRADS 1.2, is PIRADS 5 lesion. So we can take a look, another look on coronal images and also on sagittal images. And here we have this lesion. So I think I have shown everything, and I have 5 minutes left for questions. So if anybody has some questions.
So thank you, Ruta. questions. I don't see questions on the Slido platform. Actually, after these few cases, I think I will start to report the prostate MRI. So as you remember from Rūtos Grigienė presentation, beginner should start with 400 cases. So 4 or 5 cases you presented. So we can count that. Yeah.
You already have 5 cases.
Yes. Thank you very much. So no more questions. But still, I think that's very good idea to show for the audience how we really do the work, how we find these lesions, and am I right? When you start find the lesion in the peripheral zone, so you should look at the ADC and then to T2, yeah, or vice versa.
I think everyone can make his own how he is looking for any lesions. But if we know that the main our sequence for peripheral zone for clinical significant lesions in peripheral zone is ADC, so it's normal that we are starting from this sequence. And on transitional zone, the main our sequence is T2, so we are looking for those lesions on T2. And anyway, we have to look for all sequences and to get every information in one point, and then just do our any conclusions. As you saw that we can have hemorrhage, and this hemorrhage could do a lot of this misunderstanding what you are seeing on your, for example, T2 images or DVIs. So it's really important to look for all sequences. It's not all those sequences are done not for fun or for our consequences.
And actually, it's very important also to have the MRI before the biopsy done.
Yes, and MRI should be done not earlier than 6 weeks, but better 8 and more weeks after biopsy. But of course, the best would be before biopsy.
Yeah, and even in the guidelines of European Association of Urologists, they even changed. Last year I saw that there is a weak recommendation level to perform the MRI before the biopsy, and today we have different. So we recommend to do the MRI before the biopsy.
Yes, but things happen, and
we have everything changed.
Yeah.
Thank you very much.
You're
Thank
welcome.
you very much.